A good day to all. Thank you very much for this chance to be participating in such a successful conference. Thank you, dear professors and chairpersons. Today I'm going to present a case. This case, it is a common presentation we actually see in our day-to-day practice, but with a twist. So let's begin. My patient, she's a 16-year-old female. She was brought into the clinic accompanied by her mother. She was complaining of polyuria, nocturia, urine incontinence, polydipsia, weight loss in spite of good appetite, lack of concentration, and easy fatigability. This girl was diagnosed with type 1 diabetes since 5 years. She was on pre-mixed insulin twice daily, 10 units for the morning dose and 8 units in the evening dose. She had recurrent admission to the ICU due to poor compliance and recurrent diabetic ketoacidosis. On examination, the patient was pale. She had angular cheilitis, but her vital signs were all normal. Her chest and heart examination was unremarkable, but while examining her neck, there was evidence of multinodular goiter. Her abdomen showed marks of lipodystrophy due to recurrent insulin injections. There were no signs of peripheral neuropathy, and her fundus examination showed normal disc and vessels. This patient, her weight was 30 kilos, and her height was 139 centimeters. Her BMI was 15.7. She was underweight. There were no signs of puberty, no menarche, no breast development, and no axillary or pubic hair. She was a Tanner stage 1. Routine lab investigations were done. Her CBC showed a picture of microcytic hypochromic anemia of hemoglobin 9 grams. She had an elevated glycated hemoglobin, 12.5, fasting blood glucose of 298 milligram per deciliter. Of course, she was uncontrolled. There was also slight raised or elevated liver transaminases. Her urine analysis showed a glucose of 3+ and ketones of 1+. Thus, an ABG was done, and she had a picture of metabolic acidosis. Thus, this patient was admitted for treatment of DKA, and she was shifted to a basal bolus regimen. Patient education was given on diet, insulin regimen, and insulin injection site rotation. Up till here, it's a very common case, and everything was related to diabetes. But there were certain red flags we need to look for. Why did the patient have anemia? Why did the patient have a multinodular goiter with no treatment? So we had to investigate further. On admission, we did the TSH level. It was very low, with a free T3 and T4 were elevated. She had TSH receptor antibodies positive and anti-TPO positive as well. She had low estradiol with high FSH and LH. For the anemia, we investigated, of course, with an iron profile. She had a low iron profile, but also she had low vitamin B12 and low vitamin D. We did radiological investigations. An ultrasound abdomen was done. She had a bright echogenic pattern indicating fatty liver. An ultrasound neck was done. She had enlarged thyroid gland with increased vascularity and multiple small nodules ranging from 1 to 2 millimeters. Thus, the positive findings in our patient, she was uncontrolled type 1 diabetic with DKA, a multinodular goiter with a positive TSH receptor antibody suggestive of Graves' disease, microcytic hypochromic anemia with iron deficiency, vitamin B12 deficiency, and vitamin D deficiency. She also had a short stature and delayed puberty. So we had to think, what differential diagnosis do we have for such a case? Of course, we know chronic diseases like diabetes can disturb physiology, affects the linear growth and pubertal development. But severe growth retardation and pubertal delay in diabetics can be diagnosed as Moriarty syndrome. It is rare due to the improvement in the glycemic control and insulin delivery. Moriarty syndrome was characterized by hepatomegaly, Cushingoid facies, elevated transaminases, type 1 diabetes, growth failure, and delayed pubertal maturation. But we should not only stop here. Thyrotoxicosis as well can cause delayed puberty and the weight loss and deterioration of the glycemic control. As for the anemia, also the chronic diseases such as diabetes and thyrotoxicosis can cause the anemia, but we should not stop there. We need to screen for celiac disease or the malabsorption syndromes. So for this patient, the anti-T2G, IgG, and IgA were done, and they were positive. Even though she had no diarrhea and no irregular bowel habits, the only positive thing was their anemia and angular cheilitis. Of course, celiac disease was later confirmed by an upper GI endoscopy. This patient was managed, the treatment given for type 1 diabetes, as I previously said, a basal bolus regimen, insulin glargine, and aspart. For thyrotoxicosis, she was given 15 milligrams of carbimazole daily, parenteral iron replacement twice weekly, vitamin B12 replacement twice weekly, and vitamin D, 2,000 international units daily. She was given, of course, given advice for a gluten-free diet, low-carb and high-protein diet. After a 6-month follow-up for the patient, her glycated hemoglobin reduced to 7.4, hemoglobin was increased to 11.6, TSH was 1, menarche appeared, and the weight gain was 10 kilos. What are the key messages important for such a case? Of course, initial diabetes education and self-care training should be provided by a multidisciplinary team. And this will reduce the number of hospitalizations and emergency room visits, and of course is more cost-effective. The problem is with the adolescent age group or the teenage age group, they are lost between the pediatric endocrinologists or internal medicine specialists. We need to monitor them closely. Their growth should be monitored. Their weight gain should be seen if it's insufficient or excessive. During puberty, there should be assessment to anticipate the changes for insulin requirements. We, of course, need to examine the insulin site injections for evidence of lipohypertrophy or lipoatrophy that could alter the insulin absorption rates. Type 1 diabetics, we should check for thyroid enlargement. And according to the standards of medical care of diabetes in the ADA 2022, type 1 diabetics should be screened for autoimmune thyroid disease after diagnosis and periodically thereafter. We should also screen for the malabsorption syndromes or celiac disease, even in the presence of gastrointestinal symptoms or signs, or it's like in our patient, just laboratory manifestations of celiac disease. Thus, for all our patients, we need to recommend schedules for the glycated hemoglobin, urinary albumin creatinine ratio, tissue transglutaminases for celiac disease, lipid profile, and thyroid stimulating hormone. Thank you very much for your attention.